Good morning. Welcome to I'm sorry, I keep saying good morning, and I realize it is evening in India. Um, so good day wherever you are. I want to do a sound check and make sure that our colleagues from India can hear us. Is there somebody who can come on the microphone or camera and just say hi? Is there anyone in our attendee list who can hear me? There's also a react button or a hand raise button. You can click any of that if you're a little microphone shy. Awesome. All right, terrific. Thank you. Just wanted to make sure that we were doing a good tech check before we got going. Good morning, Dr. Santaki. Please come on. There we go. Awesome. Terrific. Is Dr. Oh, your microphones are muted. Okay, give me just a second. Try again, please. Dr. Santaki, are you able to?
Good morning. I think it is working now.
It is working now. Fabulous.
Perfect.
Dr. Maheshwari, are you on? And my apologies if I mispronounced your name.
I see that some people have said good morning in chat. If you have that ability, please go ahead and say hello to the rest of us. And again, I misspoke and just said good morning. I'm here in Pacific time on the west coast of the US, just north of Seattle, Washington. So it is still very much morning for me.
Dr. Santaki, your camera will work. The Dr. Miller did set the cameras and microphones to not work automatically, um, just to make sure, particularly for the cameras, that we didn't overload anybody's systems, because sometimes having all the cameras going with everybody fiddling. Oh, Dr. Miller's here. Hello, Doctor. Dr. Miller, I did turn on Dr. Santaki's camera and microphone, and I can turn on anybody else's microphones. Um, Dr. Maheshwari, are you online? Well, it looks like we're filling up with a lot of people here, so thank you for coming. If you would like to, in the chat, introduce yourself, please feel free to do that. That would be terrific. Dr. Maheshwari, are you online? We're getting a lot of names and I'm not quite seeing you yet. Welcome, Ms. Johnson. Glad to have you here. Dr. Maheshwari? Well, we are certainly picking up extra attendees. So welcome to everybody who's just joining us. Uh, if you would like to say good morning in the chat or leave your contact information or just say hello and where you're representing, that would be fabulous. We'd love to see who's here. While the presentations are going on, just a little bit about our format. We have each presenter from Pierce College, Mary Schoenfeldt, and RTMNU. We will have um, folks presenting for 20 minutes on disaster mental health, and then we will have an approximately 20-minute question and answer session. Right now, you are coming in automatically muted, so that if somebody has a setting on their computer to come in unmuted and their dogs are barking or whatever, we won't end up having that disrupt the presentations. When we get to the question and answer, I will definitely be able to unmute you and also be able to turn your camera on so that you're able to um, join in and ask your questions and everything of the presenters. So we are just giving a couple extra minutes here for everybody to come in, and I'm hoping Dr. Maheshwari is here soon as well. There's so
Hello,
many
ma'am.
names.
I am here.
Oh, terrific! Good morning. Thank you.
Hello, good
Morning.
morning. It's
There's so many
evening for
names. I was
us.
missing you. So our two speakers are here. Would you, am I saying your name correctly? Maheshwari? Am I close?
Yes, ma'am. That's completely fine.
I'm probably bagling it, but you were too kind. Um, um, would you like to present first, or would you like for Dr. Schoenfeld, gosh, I know Mary's name, Schoenfeld to go first?
Ma'am, anything is okay with me.
Well, we
If
would
ma'am
love,
wants to start first, she can do it. Then I'll be the second presenter. So whatever
okay,
suits her.
well, that sounds fabulous. We will get started here in just a moment. Um, Doctor, now I'm anxious about your name. Sorry. If you would like to, I'm going to put my email into the chat. If you would like to send me your presentation, I will get it loaded so that after Dr. Schoenfeld is done, we can go ahead and load yours up, and then I would give you control to manage your own presentation. Does that work okay?
Yes, that's perfect.
Okay. Um, so I will, in just a moment, once Mary gets started, I'll put my email in. And then if you want to email me your slides, I will get those up for you so that they're loaded. And also, why don't we start with a presentation of who you are? So, Mary, would you like to introduce yourself and your background?
I certainly will. And first of all, thank you everyone for joining us. Isn't it a small, wonderful world that we can do this all the way around the globe and come together and spend some time chatting and talking and learning from each other? I just am amazed by that capability. My name is Dr. Mary Schoenfeldt, and I teach at Pierce. And among many classes that I teach, the one that I recently created and taught was about disaster mental health for our responders, for our emergency managers. So I'm very, very proud of that. My background includes being an emergency management professional and having a passion for disaster mental health and what happens to people when they are confronted with one of their what they hope is the absolute worst day that they will ever have, is whatever that crisis was. So in my career, I've had the opportunity to teach and certainly to create training programs, but then most importantly, to respond and actually be able to be there and help folks as they are working through some of their most incredible experiences. So that's the surface. The technicalities, they don't matter so much as um, just simply experience combined with education. And I'm excited to learn from Dr. Maheshwari as well as having this conversation with all of you.
Terrific. Thank you, Mary. Dr. Maheshwari, would you like to introduce yourself? I am afraid I may have stacked a couple tasks on her. So, oh, there we go. Fabulous.
Yes.
Sorry.
Hello to all of you. First of all, it is really nice being here and seeing so many people attend this. So I am Anjan Maheshwari. So I have a background from psychology. I have been teaching it since last 7 years. I work as a full-time counselor. So and I have had the experience compared to Dr. Mary, my experience is very little. I'm in the beginning of my career. I have published some papers that are related to mental health, as well as presented them in various national as well as international conferences.
Fabulous. Thank you. Uh, Welcome to everybody who's here. If our guests would like to introduce yourselves, you certainly may. Please feel free to join in on the chat. We will, and we will also be moderating for questions there. And feel free to interact with each other as we're going through. One thing that we would like to also say is that this presentation is being recorded. And so we will chop off the beginning where everybody said hi and start with the presentation part that we've just been going through and make that available for any of your colleagues that are unable to have made this session. We know that it's starting to push into summer session for both our students and for yours. So that will be available should you guys have folks that want to be able to take a look at that. And also, Pierce College is an institution that provides badges. So we will provide you electronic badges for your participation here. And if you are able to attend all 6 sessions, you will get an overall badge for full participation in this that you would be able to share with colleagues and show that you participated in the different sessions. So if we'll take those from the email list for anybody who's participated in the first 2 sessions. We have issued badges for the first session. I will be issuing badges for the second session, probably tomorrow. We have found that some of the emails that were provided were typed in incorrectly. There were some typos or something. So my email is in this presentation. It's up in the chat. lborkhardt@pierce.ctc.edu. If you are participating in this offline, looking at the presentation later, or if you realize that you have not gotten a badge by the end of the week for the first or the second session, please feel free to email me with your correct email, and I will be happy to reissue that badge. All right, so let's go ahead and get started. And Mary, I am going to start the presentation for you. And here
Okay.
we go. Here's your window. Slideshow. Beginning. And you should see take control there. All right.
I did
You
that.
have control, ma'am.
I now have control. Thank you very much. Greatly appreciated. And again, I am so excited to be able to be a part of this small world where we're going to talk about disaster mental health for the next little bit. I often will start my presentations with that image of a battery because I mentioned a little bit about my background in my introduction, but I also know this topic from a professional level and also from a personal level, having been the one that has been confronted with some kind of a crisis or a disaster and finding myself absolutely worn out. And that's what this battery represents to me. I look at this battery and I think, boy, there's still a little bit left in there, but there's not much. There's not much to do whatever that job is that's still in front of me. And that's whether that's in my professional life as an emergency manager, or whether that's in my personal life as a mom, as a grandma, as a kitty mom, right? Do I still have what it takes? So I often will start with that battery. And when I'm talking disaster mental health, and particularly in our short time today, is I'm talking about all of us, not just those people that I call them our community members, our constituents, those people that we work with and that we have chosen professionally to support. Those people, absolutely, when I'm talking about disaster mental health. But I'm also talking about and want to talk today about what happens to us. What are the mental health implications for the work that we've chosen to do? So let me get going here and advance that slide. And I'm waiting for it to advance. I'm sure it will. I keep clicking on the right buttons. Lenora, I'm going to ask you to take control if you don't
Okay.
mind, and then advance my slides for me. For some reason, my computer has decided it's not going to answer what I want it to do this morning. So, disaster mental health, oftentimes I talk about this topic not even using the term disaster mental health. I use the term disaster stress management because I'm not talking today about that long-term clinical kind of mental health challenges that disasters will create for some people. Certainly that's an important topic, and we need to spend time there. But there are things that lead up to that period of time. So when I'm talking about disaster mental health, lots of times I will call it disaster stress management rather than disaster mental health. And what it is, at least in the beginning, it's relieving some of the pressure. And the graphics show a pot on a stove that's starting to boil over. And so disaster mental health and disaster stress management is taking that lid off and allowing some of that pressure that's built up to be released. It isn't always let's come off of our job, let's stop doing what we're doing and take care of whatever needs to be taken care of. It is truly meant to keep people productive, meaning keeping us as emergency managers working and keeping our community members capable of responding and of doing whatever is in front of them. Next slide, please. This graphic that shows disaster recovery is one that I use when I'm teaching a recovery course. And it oftentimes for emergency managers, we think of it as being, let's get our bridges rebuilt. Let's rescue people. Let's make sure that we've got communication. And I want to talk about it in terms of response and recovery actions for trauma because it's the same continuum. It starts with things that people can do prior to that, whatever that event is, and then there are some things that we can do right away, and then there are things that we do longer term. Next slide, please. People get confused talking about disaster mental health. Often I'll hear people use the term grief in reference to whatever's just happened because of that disaster. And grief and traumatic grief are different, and they need to be handled a little bit differently. Grief isn't just about death. It's about loss. It's about losing your community. It's about questioning whether or not you made the right decisions. Um, it's about losing culture, losing the traditions that you once had. All of those are factors within a disaster. So when we're looking at the reactions, it's more than grief. Next slide, please. And trauma, it's certainly psychological, it's emotional, but it's also a biochemical response. It's physiological. Next slide, please. And what we know is that trauma impacts all of our systems, whether that's the way that we think, that cognitive, our ability to take in information and then be able to make some sense out of it. It's emotional, puts us into a place in some brain science research tells us it takes us and puts us back into a place in the brain that is about processing information. Physical, and our joints hurt, our heart rate goes up. Spiritual, it impacts, it shocks our system of what we believe is fair in the world or just, or it shakes our beliefs, and it shakes our community, our social connections. So trauma, whatever has come as a result of that crisis or that disaster, has shifted our universe, and it is impacting all of those systems that make up who and what we are. Next slide, please. A little bit about just the brain science, and there's some really great research these days that's connecting that emotional reaction, that psychological reaction that we know to a crisis or a trauma, and the brain science of what happens or survival chemicals. And the short version is that there's at least 132 of them with some very complicated names from my perspective, not being in the medical field, but they impact how fast our heart beats. It impacts how we digest our food. It impacts what we can see and what we can hear. In fact, there's science that talks about how our peripheral vision actually narrows when we are in some kind of a traumatic situation and these survival chemicals take over for us. Depletes our immune system, upsets our stomach. And here's one of the most critical pieces is those 132 survival chemicals also impact how we think, how we take in information, the kind of decisions that we make, how much we remember. It impacts our judgment. And the reason for that is what those survival chemicals do is they take us from the front of the brain, which is where we're making our good decisions, and it pushes us back to this midbrain, which is about fight or flight, and it's about fear and vulnerability, and it's about emotion. So next slide, please. And so there's a chemical reaction that goes on as well. In getting ready to spend a little bit of time with you today, I did some research on your country and some of the things that I know that I've learned that have happened in India. And I know that we've had some similar kinds of events. I know that you've had an incredible mudslide and that destroyed communities. We had one of those as well. So I thought that would be good context to speak about who's impacted because of something like that. Next slide, please. With the mudslide that was here in the US, I happened to live in that community and responded as an emergency manager into the Emergency Operations Center and was active for more than 6 weeks. So what I know about that incident is that I was assigned to coordinate mental health, and not just for community, but also for all of those responders. So the very first thing that I needed to do and that my team needed to do was we needed to start thinking about who's going to need something and what are they going to need. So a really, really quick kind of triage. And that helped to guide, didn't tell us exactly, but it helped to guide some of our reactions and some of our activities. Next slide, please. We know from research that was done 30 some years ago that there is a predictable pattern, both emotionally and behaviorally, when people are confronted with some kind of a crisis or a disaster. And I call it the roller coaster. And we certainly do, we do this kind of a pattern. We start with, gee, we can't believe it quite happens. Then look at us come together as a community and we do fabulous things and we take care of each other. Then we float around going, aren't we great? But then, and this graphic shows it as disillusionment, but that's anger and frustration and depression and all kinds of other negative pieces. And then slowly we start to assimilate what it is that that event means to us and what it has done to us. Next slide, please. I want to switch gears and I want to talk about us, right? We're talking a little bit about everybody, and certainly we need to be looking at what can we do to help our community members. But I want to turn that around because partly because of that brain science, right? That says that when we are under some extreme stress, then we stop using this frontal part of our brain and we go back to other parts of our brain. That happens to us under pressure in an emergency operations center. So if we just look at what are the typical causes of stress in a workplace, it's needing to get things done quickly. It's having more to do than we think we can get done in a day. It's putting in long hours. It's not feeling like we have all of the ability to make the decisions that we want to do. It's being asked to do things that maybe are out of our regular routine and maybe even out of our skill level and our comfort level. That's typical stress at a workplace. Now overlay that we are emergency management professionals and we have just had some sort of a crisis or a disaster or an emergency in our own community, and we are in a leadership role that says we're making life-changing decisions for other people, maybe for our own families as well, but certainly for other people. So, when we overlay that, what we find is that there's some repercussions or some challenges to that. Next slide, please. There was a study that was done, and I would be glad to send an article about it to anyone who is interested. There was a study that was done maybe 2 years ago now, by the Journal of Emergency Management. And in the study, they asked emergency management professionals of all kinds, whether that was private business, whether that was college, higher education, whether that was government, whether that was a nonprofit, whether that was a business, and to answer some questions. They got more than 1,000 people that were willing to answer those questions, 902, and that actually they were able to glean some information. The most important part of that, the results of that study for me, is that that study showed that 53%, so a little over 500 of those people who answered experienced what's called mild to severe secondary traumatic stress. Secondary traumatic stress means didn't happen to me, I heard you tell about it, or I was close, but it wasn't me. It sometimes is called vicarious trauma. So 53%, more than 500 of these people said, yeah, I've had some mild to severe secondary traumatic stress. 29%, so almost 300, moderate to severe. And moderate to severe secondary traumatic stress directly impacts our ability to make good decisions. It impacts our judgment. It impacts how we lead. So this study for me just reinforced that there are some things we need to do to take care of ourselves so that we can better take care of our community members and the people that we are in the world to take care of. And that includes our own family members. Next slide, please. Some of the things that were identified, not only in that study, but have been identified in a collection of other ways, that these are the things that increase our stress and our trauma, as well as they do the same things to just human beings in general. But I want to keep it focused on us for this last couple of minutes that I'm going to get a chance to chat with you. So some of the risk factors: isolation. We oftentimes in an emergency management position feel as though, gee, it's just us. And in fact, lots of emergency operation centers they're designed to cut down on distractions. So it does feel as though we are isolated. Exhaustion, being too tired and working shifts that are much too long from a mental health and a physical health perspective. And the stigma in this instance means people don't understand what our job is. They don't understand what it is that we're supposed to be doing or that we do. And they don't see us oftentimes as being that professional responder that maybe somebody who was out there actually in that mudslide might be perceived as. Lack of adequate staffing. We never have enough people. We have multiple roles, not sure, unclear expectations. And that's the nature of disasters. We're not sure what's coming next. So we're not sure what to expect. And then the last one, at least from this collection of studies, is unresolved trauma and the domino effect. How many of us go from one crisis to another crisis to another crisis, or we have polycrisis, meaning that we've already got a mudslide and now we've got something else that happens in our community, so that we don't ever get done from being in the midst of this emotional turmoil, if you will. Next slide, please. So if we go back to what I started with, what are some of the things that we can do along that continuum, not in the way of building bridges for our community, that's an infrastructure piece, but to resolve or to support ourselves and those that we are interacting with. What are some of the things that we can do? And that's how I want to end what I want to share today. So next slide, please. Does this work? Right? I'm just a little stressed. Oh, I'm a little tired. I'll just drink this little cup of coffee. I happen to have one in my hand, and then everything will be okay. Does that work? Not in the long term, it does not. May work in the moment to kind of give us a little bit of a boost, but it doesn't in that long term for sure. Next slide, please. So here's some of the protective factors. We talked about some of the risk factors, but here are some of the protective factors that can help to reduce that stress and trauma and help us with that disaster stress management or that disaster mental health. Knowing that we're not alone, having social connection, certainly within our profession, but also outside of our profession, is one of the things that we know that will help to cushion a little bit. Making sure that we really do have time for the rest of our life other than just simply what our professional world is and what our work is. Supportive culture and tradition are a couple of things. I've done been a part of some studies in Native American communities, looking at what is it that is helpful for Native American and indigenous folks in responder jobs. And what we found is that tradition and rituals and culture, supportive culture, made a difference. Clear expectations, well, we're never quite going to get that in emergency management. We do our best. And then access to some kind of professional help beyond this when that's called for. And being willing to accept that help, and then as an organization finding ways to make that okay for our employees or for our team members to say, you know what, I need to talk to somebody just for 10, 15 minutes, 30 minutes, or I need an appointment with a counselor or with something else. Next slide, please. So looking through the US and thinking about what are some of the tools and some of the resources that are used and are available during crisis and disasters. Just want to highlight a couple of things. I've got Pierce College up here, and that's because of not only the supportive environment and what I think is a great curriculum for emergency managers, and that a part of that curriculum is actually having a class and having a conversation about disaster mental health. It doesn't just stay in the psychology department of our college, it's being brought into that professional education. In the United States, we have an organization that's called the National Volunteer Organizations Active in Disasters. It's known as VOAD. And VOAD is where all of the nonprofits of some sort that do disaster response, they are coordinated, they are supported, they are well known, they are approved, they are vetted. And so there are many of those organizations that provide some kind of emotional or mental health support and to our community members and then to us. One of the other things is just being able to do what's called a peer support team or peer support program. And those are programs that are, we're getting quite a resurgence of those in the US and now are being brought into the industry, if you will, into the profession of emergency management. And that's a program where I, as an emergency manager, I am trained and available to go help in another situation in another community just to support the emergency managers. So peer support teams. Being able to sit and chat and to have people that are trained in this thing that's called compassion fatigue, as well as disaster stress management, and being able to do that has proven to make a difference. Community connections, pulling our community together and giving them some support in connecting socially, as well as giving them information that says, you know what, if you can't sleep or your stomach hurts, this is why. And here are some simple things that you might be able to do about that. We also have here in the US something that's called the Disaster Distress Helpline. And it is a phone number you can text. There's even now a short version. You can just text 988. And we're making some movement that, and I'll go back to my my work with tribal communities. If you dial that disaster distress helpline number and you identify that you are a tribal member, then that gets connected with someone who culturally understands and is also a tribal member. And then the last image that I have down here is just people sitting in a circle in that particular graphic, chatting with one another. And that's that breaking through that resistance that says, gee, I'm having trouble sleeping, but I'm not going to tell anybody because they'll think there's something wrong with me. And that happens not only in our community, but also in our profession. So it's creating those spaces where people can spend some time. Next slide, please. And let me end with this because I'm very anxious to hear what Dr. Maheshwari has to say. And one of the things that I know is that people look to us to be the ones to be the reassurers, and we are, and we do a great job of that. But the question is always then who reassures us? And that question is answered in a number of ways, but part of it is by having these kinds of conversations. I am going to end with that. And I greatly appreciate your being a part today. And I will put my email in the chat. And I would be glad, I would love to have conversations with anyone who wants either that research or just simply wants to engage in a conversation. So thank you.
Terrific. Thank you, Mary. Appreciate that. And Mary is going to hang around and be available to speak to everybody in our question series. Dr. Maheshwari, I got your file as a PDF and not as a slideshow, which means I can't run it
Yes.
through PowerPoint.
Um, can I try sharing it from my end?
Sure. Um, let me. We make you a presenter, then you should be able to take. So if everybody
I
would like
I
to go
I
ahead,
am a presenter already.
you are in the slides. Go ahead and try your sharing
Yes.
then.
Just give me 1 minute. Yeah. Is the presentation visible to all?
Yes, we can see it. Thank you.
Okay. Perfect. Can I start?
Please go ahead.
Okay. Thank you so much for this opportunity. So, as you've already gotten an idea of about what happens during a disaster or how things come into picture, so I would just elaborate a bit or continue on the topic. So, when I came across this topic, mental health in disasters, my first question that came into my mind was, why is it necessary? So I was just thinking about it and I realized In Indian culture or Hindu culture, we can say, there's something which is known as Mahabharat. Uh, in Mahabharat, during the war, many characters they displayed characteristics where their mental health was at question, and they received counseling from somebody, and that helps them to reach the correct place. That made me understand that mental health was important ages and ages ago. So it is something which is definitely important even today. And uh, in disasters, it takes a little more importance because we are primarily focusing on the infrastructure, on the medical issues associated with it, and many times the psychological aspects of the disaster are overlooked. So, in the presentation, I'll be covering four important points. First is what is the impact of the disaster? Then, what role do we as mental health professionals play? What strategies can be used to help people with the effects that they are facing? And most importantly, we'll be talking about community resilience. Now, all these topics they are very in depth, but due to time constraint, I'll try to put everything in the 20 minutes that I have been allotted. Now, before we dive into it, what do we understand by a disaster? So, disaster can be anything, a sudden accident or a natural phenomena with a characteristic that causes great damage, loss of life, and damage to the flora, the fauna, the infrastructure. So, disasters, they can be natural disasters, earthquakes, tsunamis, as ma'am talked about, landslides. Even in the US, typhoons and all, they are very common. Uh, Earthquakes in India are common, or they can be man made. Man made disasters are like wars or some oil spillage in the ocean or some gas leakage at a huge facility. Then, when we talk about disasters, it happens in phases. So, first is pre disaster. We should always believe that we are in a pre disaster phase. Anything can happen, and we should always be prepared for what is coming our way. Then comes the impact, that is the immediate when the disaster takes place. The next phase is response, the immediate response. And later on comes the recovery part when we are trying to deal with it. So, when we talk about mental health, pre disaster, we need to take care of it. And during the response and the recovery phase, we need to give a lot of importance to it. Then we come to the psychological aspects of it or the impact that it has since it is mental health. So we need to understand that disasters they impact your mental health at an immediate level, in short term, and in a longer period of time. Whenever any disaster is there, the immediate impact is that there's a lot of fear since it comes with uncertainty. There's shock, there's confusion. You did not see it happening. You did not expect that this is something that can happen. Then, when we come to the short term impacts of it, there's a lot of anxiety since there's a loss around you. So there's anxiety as to what will happen. Insomnia, there's lack of sleep. The person becomes very irritable very quickly. These impacts we understand, but many times the long term impacts of disasters are overlooked. In the long term, there's grief, there's loss. Uh, Many a times it leads to substance abuse. There's chances of depression. There's a disorder, a psychological disorder that is known as post-traumatic stress disorder. This disorder comes into a picture once you have experienced a major trauma in your life. So many people who have experienced some uh, earthquake or a tsunami or a war may have PTSD for a very long time, which is characterized by recurring dreams about the same and situation, constant anxiety. Okay, there's something which is known as survivor's guilt. Now, for survivor's guilt, many times in disaster, some people lose their lives. Some people who are fortunate enough to survive that disaster suffer from survivor's guilt. It's a question as to the people around me could not make it. Why did I or how could I? So, these happen to be some of the impacts associated with disasters that has on your mental health. Then, whenever a disaster strikes, all of us are vulnerable to it. But there are certain populations for whom it is more difficult than others, especially for children or adolescents. Okay, like they can internalize the trauma, uh, and it can be with them for a very long period of time. The elderly is because physically, as it is, they are not at their prime. The disaster adds to the problem. Anybody with a pre-existing mental health condition would take a hit in a stronger way, in a worse way. Then these are the people who have experienced disaster. But the people who respond to it, that is us, okay? The first responders, the mental health workers, the healthcare workers, it is extremely difficult and extremely traumatic for us also. So the first responders and the healthcare workers, they also become vulnerable because responding to a mass tragedy or a disaster is very difficult. Then, what does a mental health professional do? So, during the pre disaster time, we basically work on risk assessment and preparedness learning. As I said in the beginning, somewhere we are always in the pre disaster zone because we don't know what can happen. So, we have to be in the position where we're preparing everybody for what can happen and how we can manage it. During disaster, psychological first aid and crisis intervention, as a medical first aid is given, similarly, psychological first aid is also given. The immediate response, the first conversation, the first care, the first mention of mental health. Then there has to be various kinds of therapy, trauma therapy, grief counseling for people who have survived it, rehabilitation because the infrastructure, the houses, the societies are not there. Government, NGOs, they all come together to make it a better option, to make it that people can survive the disaster. Building the capacity so that we can deal with the problems that have come into our life, and training local people that they can help the ones who are in need. Many times, due to remote areas, it is not possible that the help would always reach. So, the people who are there, they can be trained so that they would be in a position where they can help people who are suffering the disaster. Then, these are some of the strategies. Now, when we talk about the strategies, uh, I am not going into a very detailed clinical discussion. Certain things are left for professionals, but as a first responder or as somebody who would get involved or who would like to help. These are just some basic strategies which can work with psychological effects of disaster. So, psychological first aid becomes very important. So, you listen without pressuring people. You listen to understand their situation, you listen to understand their trauma. You try to establish safe spaces, community shelters where people would feel safe. When you feel safe physically, you start feeling safe psychologically. Then promoting psychoeducation and emotional literacy. This is something that would happen in the pre-disaster phase, where we promote, where we prepare you for the problems that can come. Then early screening and referral systems. Whenever we are providing the psychological first aid, we can understand who requires help first and who requires help after that. So we can have an early screening of the most vulnerable population, and we can refer them to highly professional people who would help them deal with this. Currently, we live in a time which is governed by technology. During disaster times, technology can come to a lot of help if used correctly. So telecounseling can be done. Okay. Telecounseling is basically you provide with helpline numbers. People can call, people can talk. So the physical closeness which is required for therapy, that does not remain a requirement anymore. So certain counseling, telecounseling or cyber therapy methodologies can be beneficial. And mobile mental health units. Mobile mental health units are basically a group of people who are trained to deal with mental health during disaster times, and they can be placed in a disaster situation. They are mobile, so they can move around. Like an example of this would be in Nepal, I think around 8 or 10 years back. They were hit by a 8-pointer magnitude earthquake. So, Nepal, not being one of the highly developed countries, they had these mobile mental health units. So they could make these people reach out to the people who were in desperate need, and they could make it better for them. And you can empower the survivors that they come together and help each other recover. Since they have been in the problem together, they can be motivated to be in the recovery or the solution together. And what trauma they have experienced, only they can talk about it. An outsider will never be able to understand them in a perfect manner. Next, this is, I feel, one of the most important part of the entire presentation, that is community resilience. What is community resilience basically? It is how well at a community level you can withstand, you can adapt, and you can re recover. So, when we talk about any disaster, okay, it takes place at a communal level. So, even though personal resilience is very important, overall community resilience is important. So this is something which happens in the pre-phase or just during after the disaster. How well the community can come together, help out to each other, and deal with the disaster or deal with the problem that has come into picture. So disasters, they do not affect individuals in isolation. They impact the families, the neighborhood, the population. So collective capacity that we have makes it a bit easier to deal with the disaster. Now, some of the key components of a resilient community is social support networks. So, having people around you who would help you or who would be there for you in time of need is very important. Social network or social support in general helps in a better mental health. So, resilient communities, they have close knit relationships where people try to look out for each other. Okay, so they give emotional support, practical support. They help to pass on information quickly, giving that first aid, giving the resources, giving a camp to people. So that is what social support does. Then leadership and communication during the time of disaster, if we need a proper leader on whom we can depend, who would guide the entire population in what is to be done, and communication becomes a major aspect. How well the instructions can be communicated, that becomes very important. Clear, credible, and consistent communication before, during, and after a disaster will inculcate the feeling of resilience. Then, cultural and spiritual coping mechanisms. There is a lot of cultural difference, a lot of spiritual difference. These differences uh, will lead to difference in coping mechanisms. So we need to understand what is their culture, what are their spiritual beliefs, and on that basis, coping mechanisms come into picture, and on that basis we need to make sure that we can help them. uh, then community as a whole, when the community as a whole is empowered, they will face each and every problem as a whole. So community resilience helps in faster and more coordinated recovery. Psychosocial well-being, it helps. It builds a culture of being prepared. So community resilience, it becomes a backbone when we talk about sustainable recovery. So when people, they come together, they survive the disasters and they come out as stronger people. Okay, it is not about bouncing back, it is about bouncing forward, and bouncing forward together. So community resilience is extremely important when we talk about disaster management or mental health in disaster management. Then, one thing that we can tell is, nobody is ever fully prepared for disaster policies, for disasters. So we need to integrate the mental health into disaster policy. So the national disaster plans that exist, so there should be training manuals, SOPs, emergency drills, where people can understand what is to be done in case of an emergency. So, giving an example of what happened in India recently. So, when it became a little hostile with a neighboring country, there were nation across drills that were preparing people for what would happen if a war breaks out. If light outs are there, how you're supposed to deal with that. There were sirens blaring. uh, so that was basically preparing it. So that was a drill, that was an emergency drill, like we do fire drills. So all these drills, when there are standard operating procedures, so in case of disasters, you know how to be. So having policies in place will help a lot in dealing with these disasters. Uh, let's consider COVID-19. So it was a pandemic, everyone across the globe impacted by it. So it was a disaster. It was a first world disaster. So many countries, they, since face to face interactions were not possible, many countries, they launched specific telecounseling centers to help people deal with that isolation, to help people deal with the loss. So even in India, there were specific helpline numbers. In India, it was named Kiran, that is sunshine or a ray of hope. So all these things, they help in making it better. They help in making it easier to take care of your mental health during the time of disaster. Then these are some of the challenges and what can be done. I'll not put in a lot of time into this. So there's still a lot of stigma surrounding mental health. So even during disasters, people don't talk much about it. During COVID-19, it took a lot of people and a lot of time to accept that it was impacting the mental health as well. Many times trained professionals are not available. Existing mental health services are interrupted, and many times we need culturally appropriate interventions which we may not be aware of. So what can be done in such a situation is we strengthen the mental health infrastructure in disaster prone areas. Certain places are prone to disasters. Like certain countries, earthquakes are common, wildlife fires are common, forest fires in Australia. So, when you know that there are chances of a disaster, so we need to strengthen the mental health infrastructure. We have to build capacity so that we can deal with high level of disasters in terms of mental health. When we talk about disaster preparedness, we need to include mental health in that. And there should be trauma informed approach in all sectors. Not only mental health professional, each and every person should have a basic understanding of mental health, of trauma, of stress, of what should be done. So a basic first aid should be known to each and every individual. So in conclusion, I can only say that disasters, they impact the mental health, but timely support from trained professionals and resilient societies, they make a hell lot of difference. So the solution to the problem of mental health in disasters is prevention, putting yourself in a situation where you're so mentally strong that you can withstand a lot of things, timely intervention, and involving the community. Okay, so thank you so much for your attention and giving the opportunity to me so that I could share a bit of knowledge with you all. Thank you.
Thank you to both our doctors, Dr. Schoenfeldt and Dr. Maheshwari. What excellent presentations. We really appreciate you both putting so much effort and time into helping us understand more about disaster and mental health. At this point, I think we'd like to go ahead and say thank you to all of our participants as well. We are just slightly over our hour-long time frame, but if you would like to stay, we would welcome that. If you have to leave, thank you for coming. And you will also have the ability to look at the Q&A session that comes after this. But if you do have to go, we wanted to say thank you. So if you would like to stay for questions and answers, we can certainly do that now. If you can look at the top of your screen, you would see a hand icon with raise underneath it. If you were to hit that raise hand button, then I will be able to activate your microphone and your camera and bring you online for any questions you have for Dr. Maheshwari and Mary Schoenfeldt, our experts on these topics. Dr. Santaki, I believe you have control to enable your camera and microphone.
I can unmute my mic. but not camera. Thank you. It's a very excellent presentation by both the speaker. My one question to Dr. Maheshwari: how how the community resilience be measured in disaster-prone area? We say it should be resilient, but how we can measure it before the disaster?
There can be drills as we talked about war situation. So there would not be a specific way to measure it, but there would be ways in which we can inculcate it. So we can have drills. We can have like the
Mhm.
session that we are currently having right now. This can be an example of community resilience. We all are trying to understand something so that when the problem arises, we'll know what the solution is or how we would be in a position where we can help each other. So we may not be able to measure it, but we will definitely be able to inculcate in people. I hope I have solved your query.
That's a proper answer, but I just wanted to know in worldwide anywhere this kind of scale or some methodology is available. Actually, that I wanted to know.
No, I don't think so. Community resilience is something which is a very new concept in the field of psychology. The
Mhm.
terminology or the concept, it's a pretty new concept. So maybe we can wait like for few time and then we may have something to measure it also. Or we may come up with something to measure it.
Okay.
Let me add into the conversation about drills, in that one of the things that I know that I continually encourage with any kind of a drill, whoever is doing it, is add that mental health piece into it. And in fact, I was working with a group and we were creating some injects that would be mental health that could go into any kind of drill, whether that was the local fire department that was drilling and about a train wreck, or whether that was a local government emergency management that was doing a drill around an airplane crash or an earthquake, that there were just simply some, let's add these two questions about inject that as an inject to talk about the mental health aspect and who our resources are.
Yes. Just add into them. You are right. Because I have been a person worked in the fire services, was responded in many real as well as the mock drills. So there normally we see the responses of the emergency services, the infrastructure equipments available, rehabilitation supports we are having, that are seen, measured and checked. But as far as the mental health and their status, then the resilience and the support that required, that is really missing out, because the person who are participating into the drill, it's a plan activity basically. So even we are creating some any disaster situation, maybe there are number of casualties are involved. We create the building collapse sort of situation or the fire incidences. So person who are involved directly, they are known to that. It's a drill, it's a practice. So they themselves cannot go through or cannot pretend that what mental stress they are having,
Mm.
or they do not experience it. Similarly, the person handling to them, they also know it's a drill. So real that response we cannot check. We can check the equipment wise whether we have that kind of rescue tools from where we can take out that person, or to reach that height to rescue those person, or to transport them to the rehabilitation center by checking the our mobiles vehicles. So that infrastructure we can check. We can note the time also. We can respond, see the how many people have responded, how many agencies responded. But this part is really missing. So as you said, this is a new concept and it is important also because that hinders the actual operation when there is an
Yeah.
actual disaster. So that way it is very important and we have to see how we can develop it so that we can have the some scale for that to measure, so that we can work upon to improve it.
Yes, that's correct.
I believe I saw somebody's hand pop up for just a moment, but you lowered. Oh, there we go. Let me allow your microphone, and I will allow your camera if you would like to come on and ask your question.
Hello, ma'am. My question is for both Mary ma'am and in displaced population, like in tribal areas or like area where it is secluded from the society. How do we identify and support those suffering silently, like women in restrictive cultures and children like without guardians or orphans? How do we like save them from disaster situation? Hello, ma'am.
Yes. So, in such situations, that is why we have mobile mental health units, because it's not possible. And considering the cultural understanding of each and every society is also important. So, mobile mental health units are something that can reach to people in different terrains, as what I feel. And having said this, I know it is a more theoretical answer than a practical one, because reaching out to each and every individual is very difficult.
And we don't have the mobile mental health capability that you have. So I'm very intrigued by that and want to learn more. But I talked about the organization here that's called National Volunteer Organizations Active in Disasters, or NVOAD or VOAD. Each state here in the US has a VOAD chapter. And in each of those VOAD chapters, there are agencies that provide disaster mental health in some form or another. So when the VOADs are activated in a disaster, then, and sometimes they are church groups, sometimes they are a nonprofit. I'm involved with one that's called Green Cross Academy of Traumatology, and we have trained disaster mental health folks that will go into a disaster situation. So we don't have the mobile that I'm hearing that you have, that I want to hear more about, but we have those resources that when they are activated, they come into a community and then are able to do some assessment, as well as to actually provide that mental health support. We also work very hard to stabilize the existing mental health community that's in that disaster that was impacted. They can't always respond immediately themselves because they are dealing with their own houses being destroyed, or their own families, or whatever those particular personal impacts are. So one of the goals of some of the nonprofits is to come in and to support and stabilize local mental health, so they are back up and able to then continue providing support in their own communities.
Fabulous. Thank you both. Are there any other questions for our mental health experts? All right. Well, it looks like, oh, there we go. Terrific. thank you. Let me put you, allow your mic, and I can allow your camera if you'd like to come on and join us. Go ahead.
Hello. Good evening, ma'am. My question to ma'am Mary ma'am and Lenora ma'am both, or Anjan ma'am also. Ma'am, in medical ma'am, we have first kit, like medical kit, like that also in like that also in ma'am in psychology during disaster management. Uh, we have any psychological kit, first psychological kit to maintain the mental health during disaster time.
I didn't understand the question. I apologize for that.
He wanted to ask, like when we talk about first aid, so there are like when we have a first aid kit, so there are some medicines which are there. So when we talk about psychological help or psychological first aid, is there a box or something that can be there? Uh, to answer that, no. We do not have a medicine or we do not have some injection. Depending upon the problem, uh, a trained psychiatrist may be able to prescribe certain medications, but nothing like nothing basic as a first aid psychological box exists. It's more of a conversation. So we are the first aid kit.
Yeah, I would agree. It's that
Yes,
cognitive
ma'am.
behavioral health. It's not there's not a pharmaceutical and kind of an intervention. We can treat some of the symptoms like digestive issues and maybe some anxiety, some other pieces, but that's treating the symptoms, not treating what the actual challenge might be.
Thank you so much for your question, and I'm sorry we couldn't quite get your technical difficulty. We didn't hear it super well. So thank you, Dr. Maheshwari, for helping us get that as well. All right, terrific. So are there any other questions that you'd like to ask our panel?
Well, I have one for Dr. Maheshwari, and that's you in your introduction, you mentioned that you have published some things about this topic. I have also, and I would love to exchange what we each have done. And maybe if
Sure.
there are some of our participants that would be interested in getting those as well, and we could share those. But I very much am interested in what you have published and what I can learn from you.
Sure, ma'am. We'll keep in touch.
I see that Mary has put her contact email if other people would like to contact her. Dr. Maheshwari, if you would like to put yours in the chat, it would also go to anyone who, or your LinkedIn profile or any way that you would prefer to be connected. But that would allow anybody who saw this at a later time with questions or an interest in getting your publications, they would be able to contact you through your preferred channel to follow up with that. All right, we have, oh, thank you very much. So those are in the chat if you would like to see them. And I think we've arrived at the end of our time. So thank you for everybody who was also able to stay on for our questions and answers with our esteemed panel of experts. And again, you can find their contact information in there, as well as I will add mine at the end as we are finishing this up. If you have any logistical concerns, if you would like to get a video of the rest of this to share with your colleagues, if you have if you would like your badge from the first two presentations and your email didn't come through correctly, or from this presentation, I'll try to get those up this week. If there's anything logistical, please let me know. I will be happy to fill those in for you. And otherwise, I will end our session here. And I hope you all have a wonderful day. And thank you for coming.
Thank you.
One of the things that we
Bye-bye.
do want to do is let you know also about next time. And if you would like to go, please feel free to do that. If you would like to hang out for just a second, I will be also putting that information into the chat so that everybody has access to our next session, which is on Indigenous ways. So I will copy that and paste that in the chat as well. Thank you very much for coming, and have a wonderful day.
Thank you.